Mood-altering drugs have always been part of organised society. The favourite drug, of course, is alcohol for most of us in British society. But other drugs have always really been there at various times and places. The interesting thing about heroin addiction, for example, which is the sort of number one concern that we have in society, it's on the wane. The proportion of new admissions for heroin treatment have halved among people aged 18 to 24 in 5 years. That's 100,000 less treatment admissions. And so the typical patient that's coming in to treatment today and tomorrow are older, usually about 40 years plus. And we're seeing, I think, a tapering out of the sort of heroin generation and the epidemic that started in this country in the late 1980s, in the sort of northwest area of England. Now, that unfortunately is not to say that the problem is about to go away. I think, regrettably, what will happen is new drugs will replace the addiction landscape. And there are some signs of that happening already. There's a worrying trend internationally for the illicit manufacture or the diversion of synthetic opiate drugs. These are drugs that work pretty similar to heroin, but they're man-made, and they're essentially pills, and they're what we call narcotic analgesics. And there's a whole list of them, which I won't try and summarize for you. But those drugs essentially have a legitimate, if manufactured, medical application. But they're also drugs that are liable to misuse and addiction, and they may well prove to replace the heroin problem for the next generation. I've chosen to study and work in the field of heroin and cocaine. Now, I'm not sure if it was the best career choice, because these are the hardest to treat addictions that we have that are illicit. But I find that work very rewarding because I think we're on the verge of discovering some very effective ways of treating people with those addictive disorders. And the work that I do is working within a multidisciplinary team where we're trialing new types of medication and adapting behavioral interventions and getting a mixture of medication and behavioral intervention in the right form for the right patient. There's been a tendency in the past to kind of develop a new treatment almost as a sort of horse race and compare it to a control or a placebo condition and just look for an averaged effect size, the average patient. Unfortunately, that's not a very nuanced way of doing business clinically, because there isn't an average patient, particularly so in the addiction field. There are groups of patients that share more or less similar characteristics, but they're often very different from other groups that have an alternative, if you like, footprint of problems. So my work is trying to match ingredients of therapy, if you like, to the specifics of the individual. And that requires some fairly clever research designs, adaptive medication and behavior therapy designs that are quite fresh, I think quite exciting, and likely to be very much the way we think of addiction going forwards.